This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So this is Alain Bouchard, and I'd like to welcome you to our podcast, COVID-19 and the Heart. And this time we're going to talk about the adult population. Joining me today are Dr. Mustafa Ahmed, Chief of Cardiology of Interventional and Structural Program at the University of Alabama Birmingham, Dr. David Fieno, cardiologist at Shelby Baptist Medical Center. So we'd like to talk a little bit about this virus. I mean, obviously, and how it affects the adult population, and particularly our patients. We know this virus. I mean, the coronavirus is actually well known. It's a positive strand RNA virus with a very large genome, and it's affected human mostly in the alpha and beta type. It's actually the cause of common cold in about 10 to 30% of the cases. And we know that it works on the ACE receptor, ACE2 receptor that we can find in the lungs primarily, but as well as in the heart in different places. The infectivity of the COVID-19 is actually greater than the influenza virus. But the coronavirus has done some damage in the past. We've all heard of MERS, which was this respiratory illness in the Middle East, as well as about 10 years ago, where we had the SARS-1, where it caused an epidemic, severe acute respiratory distress disease in South Korea. Now, this is also the SARS, but it's the SARS-CoV-2, a relative that came out of the blue, and now has caused patients to really have a lot of problem, mostly a respiratory problem. Again, in our patient population, it's estimated that about 80% have mild disease, but probably 15 to 20% have moderate to severe disease and can have their heart affected. And particularly, we know that patients that have problem with hypertension, diabetes, and have obesity are more prone to get the disease, to get the illness, and get quite sick from it. We've known of a case report now since February. We have single center reports and now multiple center report. And here with us, Dr. Ahmed had presented actually a webinar approximately a month ago about some of the cases that you had at the University Hospital. Dr. Ahmed, would you like to maybe elaborate on some of your patient population and how they're affected by COVID-19?
Sure. What's interesting about this conversation is it's going to be very different than a similar conversation 4 weeks ago. And I have no doubt that in 4 months, there'll be a very different conversation as we understand more and more about COVID and its very different effects. There is no such thing as an expert on COVID and the heart. Anyone claiming to be so just has their own experience to talk about. And again, it's a time of great humility when it comes to treatment in medicine, because all of us that have trained for a long time on issues that we considered ourselves experts on were suddenly hit with this new challenge. And it was a very amazing thing when it first came out, because we really didn't know anything about it. When it comes to heart disease, clearly has been demonstrated in the initial experience is patients with heart disease do worse. They are more likely to be more affected with heart disease. They're more likely to be more affected by the respiratory disease. And when it comes to the patients, what we call high risk. So when we say to people, you may want to isolate, you may want to be even more careful than other people. Heart disease ranks right up there with the reasons for that. And when it comes to the patients that have not done well, the people that are dying, the people that are at risk of dying and end up in intensive care units, like you were saying, the very obvious thing we saw was there's just a preponderance, there's there's more heart disease in that population, and we believe this is a risk factor. And so the topic of COVID and heart disease is very germane to the entire conversation about COVID and people getting sick. And, the initial webinars we had were, hey, how do we all get together and talk about this thing that's about to hit everyone? And what do we do? Because the way I put it back then is suddenly apples were not apples and oranges were not oranges. Let me give you an example of that, and I'm sure you guys are going to chime in. Dr. Fieno is in a busy practice. Dr. Bouchard, you are, and I'd love to hear what you guys think. But when let's talk about heart attacks. So someone comes in with a heart attack, and usually you say, you've got this chest pain as the presenting factor, sometimes shortness of breath, sometimes other things. But really what nails a diagnosis of an acute heart attack is a heart tracing called an EKG, or in England, where I was from, an ECG. And that heart tracing has a very distinct pattern. So when you go to an emergency department with chest pain, you'll notice there is a rule where we say within 5 minutes, you have to have had this EKG. And there's a pattern called ST elevation, which says there is definitely acute damage happening, and we need to get you into a cath lab, which is where the heart procedures are done, immediately. And there's a whole field which is based on getting that patient into the procedure room as fast as possible in a race against time to open that artery back up. And when COVID first came along, it was a scary time for proceduralists because people were coming in and you were having to wear all this masks and gear and protect your whole teams and not let people in the hospital get infected by this thing, not let healthcare workers get exposed, and at the same time protect patients. But what we noticed at the beginning was suddenly we were seeing these EKG patterns. We were taking the patient to the cath lab for the procedure, but we weren't seeing what we usually see. So what do we usually see in a heart attack? We see an outline of what was meant to be an artery, then boom, it stops. It gets completely cut off, and the rest of the artery is missing. And then we put a wire through there, the stent in there, fix it, the acute blockage, and blood flow is restored. And if you can do it quick enough, you save heart muscle. What we were seeing in COVID was that same pattern of disease, but there was no blockage. So what you noticed was a slow flow throughout many bits of the artery, but this blockage, you'd look for it. You'd take different views, and you go on the left and you go on the right, and you'd be like, this is unbelievable. Usually you look at the EKG and you know exactly where that damage is going to be. But then you're looking at this picture of the heart, the arteries that you've just taken, there was no blockage. So this whole field started about, everyone suddenly started saying, what is this? There's no blockage there, but there's something going on because it's led to chest pain, it's led to the acute injury, and it's led to people not doing well. And we don't 100% know what that was. We know it's there, and it's changed the way we think about heart attacks. I do want to underscore that still we treat heart attacks like heart attacks. You take the patient, you look for it, and most of the time there's a heart attack there. But now we are, in the back of our mind is, have you had fever? Have you had a cough? Have you been exposed? Are you in a high-risk situation? Because it may turn out over time that the treatment for those differ. Early studies have shown that they may be due to little bits of clot being shed into the end of the arteries in a process known as, distal thrombosis. And is that causing a blockage and damage? And we are still to learn a lot about this, but I'd love to hear what you guys say now, but I think we are seeing different patterns of heart disease, and even the classic heart attack, the bread and butter of a interventional cardiologist, even that's changed due to COVID.
Interesting. There was a case report actually from Italy, a patient that had this exact presentation and unfortunately died, but it had classic, ST elevation myocardial infarction, or what we call now a type 1 myocardial infarction. They did the autopsy, and they never found any evidence of myocarditis. What are we dealing with? Is it just microvascular and we can't see, or was this a stress cardiomyopathy or Takotsubo, which is also presents with ST elevation, positive troponin, but usually has more of a classic ballooning aspect of the left ventricle?
I very much echo your comments, Dr. Ahmed and Dr. Bouchard. I can tell you that from a perspective of a community hospital where, these folks come 50 miles to come to a 250 bed hospital, the presentation that we see is identical to a heart attack or what we call an acute coronary syndrome. And it's relatively few of them that have that ST segment elevation that you mentioned, Dr. Ahmed. What I've noticed is an awful lot of people who have what we call congestive heart failure. They have a failure of the heart to pump adequately according to the needs of the body. And the difficult part there is what exactly is the problem with the heart, which is exactly what you're alluding to, Dr. Bouchard. Is it a primary blood vessel problem where the blood vessel is not delivering blood adequately? Is it an infectious problem where the COVID bug is getting inside the muscle of the heart and creating myocarditis? Is it a hormonal thing where an adrenaline surge causes this ballooning of the heart that you mentioned called Takotsubo? Is it a combination of all of these things? And even more troubling is once you get past the initial electrocardiogram that you mentioned, Dr. Ahmed, there's absolutely no agreement on what to do with these patients whose hearts are failing. The treatment paradigm can range from very conservative care to immune therapies, IVIG, and these very expensive therapies, to essentially partial cardiac replacement therapy with machines called ECMOs that recirculate the blood. And the trouble is there's just no agreement. There's just no experience. Everything that we're finding out is based on a single center, often a single operator. We know that at least 20% of folks with positive troponins do, well, these are the markers for a heart attack that Dr. Ahmed mentioned, at least 20% of them do poorly. And of those that do poorly, it seems to be a combination of respiratory and cardiac failure in those that die. And then we also know that in the lab, the virus can get inside the heart muscle. And what it actually does there is unclear. The contribution of these inflammatory markers, these cytokines, to a sepsis-like syndrome, that changes the pressures in the heart and the loading is completely unclear. So what we know is they're very sick, and we know they need the highest levels of care of the intensive care unit. What exactly to do is just a complete and utter mystery to me.
Yeah, I think to this, I remember in March, I was reading a tweet. It was actually on March 10, and it came from this "Please stay home." It was actually from the front line in the ICU in Seattle, describing these patients. This was described by an intensivist, describing this patient with acute respiratory illness on the ventilator, and day 4 or 5 starting to do better and improving, and the following day developing the shock syndrome with this heart function that went from the 45 to 50% range to less than 10%, and developed this myocarditis. So we know that elevation in troponin, which is this enzyme released when the myocardial cell is affected, we know it's related to prognosis. I mean, we treat patients with different condition. Whenever we have a positive troponin, it's usually related to prognosis. And obviously, we have to decide, is it what we call a primary MI, what Dr. Ahmed described, with an occlusion of the coronary artery, or is it some damage or myocardial injury caused by this severe illness, or is it related to any coronary artery disease at all. This is where I think we have to really use all of our clinical acumen and treat patients, obviously individualize our treatment and making it in the context of the clinical situation, whether truly this is, a myocardial infarction that we should take to the cath lab versus a myocardial damage that we can treat medically.
Yeah, I think we're all in agreement that COVID and heart disease are a bad combination. And COVID itself can lead to heart problems with different experiences from different centers. Like you were both just saying, we got some reports from some countries that were saying, wow, we're seeing this large population of people that are coming in with heart failure. The heart muscle's gone weak, and we need to come up with strategies to completely get ready for this this large population that's about to present. But then we'd get other experiences from other countries like Italy, and they'd say, you know what, we're seeing little bits of maybe damage, but we've not actually seen hardly any major effects where the heart itself has had that effect, and we're seeing a very, very different presentation in our population. It seems like every country's maintaining its own different kind of experience. One question that did come up early on was, should we treat heart attacks differently for multiple reasons? Exposure, unknowns, we talk about evidence in medicine. I remember when I went to medical school, one of the questions I got asked in my interview was, hey, what's evidence-based medicine? And I remember having read about, saying I have no idea what they're talking about, but I remember reading about this thing and saying, oh, yes, it's a field where we draw on studies and the scientific process to inform what we do. And what's amazing now is there's very little evidence base for just what's happening in the world. And so one of the conversations that happened early on was, gosh, should we, given all these unknowns, should we treat heart attacks differently? Should we go back to the 1980s and use a clot-busting medication and give this to all the patients for the reason that we don't need to go and expose ourselves, the healthcare workers, the other patients, and we don't need to put the patient under a procedure, which is still an invasive procedure with the unknowns of that and COVID. And so in China, we were seeing people saying, we're going to take all primary heart attacks to go as far as to take certain guidelines and say that is an accepted primary treatment. And then in England, the Cardiac Society is elected to say, you know what, we're going to make sure that we're going to keep providing the usual standard of care for heart attacks and go in there and try and fix them. And David, I'd love to hear what you think about this. At UAB, we've kept primary, we call it primary PCI, or we've basically said, you know what, we'll take the precautions required, but we're going to take every single person that's suspected of having a heart attack within reason. And we're going to go in there and try and open it back up because in our mind, the worst case scenario is, one, you give clot-busting medicines to people that already may be at risk from taking those clot-busting medicines. And two, it's not an efficacious a treatment, and it may lead to a large population of people dying through heart disease. Through a heart attack that you don't open. Have you guys been having those same conversations?
Identical, Mustafa. We get a number of patients from outside medical centers that are 50 miles away in these small towns, and they'll have ST segment changes there. And it's almost caused us to pause because so many people were taken back to the lab have no blockages that, we seek to treat there and have, what we call primary treatment for a heart attack, right? And the problem is that if you just give this clot-busting medication blindly, you may give a potentially lethal medication to someone who doesn't even have a blockage. So the discussion was that, is there a role for conservative therapy, even in the event that patient is having the largest kind of a heart attack, the ST segment elevation heart attack that you were mentioning a minute ago. And there's no great answer. I think certainly when you have, as we moved forward with this, what our approach was, the more clear cut the EKG findings were, then we just bit the bullet, as you say, and everybody put on PPE. And the key there was you just assume the patient is COVID positive and actively shedding virus into the air. And I'm sure that's what you're doing at UAB as well. And then if you have a patient that's not quite so clear cut, or they're doing well so far with, conservative therapy, then there's a real role to step back and say, do we need to expose this patient, one, to the risk of the procedure that may end up showing all their arteries are fine anyway? And secondly, do we need to expose the staff? And I think that everything what's happened for the practice down south of Birmingham, everybody's just paused and thought. The elective procedures are canceled, so we have time. The patients are sicker, so they tend to have more doctors' inputs. And we have an opportunity to say, on whom is an interventional strategy up front really the right answer? Or do we have an opportunity to possibly pause and think, is there a conservative therapy we should try in an otherwise stable patient? So I would suspect that as we move forward, we're going to do exactly what you've found, is that just take a very aggressive strategy with everybody and assume everyone's COVID positive. The elective surgical center associated with my hospital is back open for business. And the approach they're taking with everybody who comes in for a carpal tunnel surgery or an epidural is that, can we just assume they're COVID positive and proceed? And I think that's basically what we have to do for the next few weeks until we see what happens now that everything's reopened. As far as outcomes are going to go, I think that everything is in light of the relative concern with the uncertainty about who is going to develop a fulminant illness due to the virus itself. And that concern is basically this: nobody knows. So I think it's just a two-step process is what is it that we always do, and do we feel like that's appropriate in this particular patient?
So, Dr. Bouchard, I'd like to ask you, you also have a phenomenal practice, and how have you seen that change? As in, the waiting room that used to have 30 patients in it now has, with 5 at a time sitting 10 feet apart and the chair washed down afterwards. And how's things happening as we start to reopen? How's the process changed with getting tests and patients coming in to see you, and this whole amazing new field of, they would take offense at me saying it's new since people have been doing a great job with it for a long time, but telemedicine. So I'd love to hear your experiences on cardiology, COVID, and telemedicine.
Well, I think what's important for us, at this stage is continue the guideline-directed medical therapies for our patient. And, whether we do this, using telemedicine or actually in person, this should be at least one of our priorities. We're seeing the patients in the office, mostly the ones that are sick, that are really needing some help. They are decompensated either from the point of view of their angina or from the point of view of their heart failure. And we have integrated the telemedicine as part of our practice now to help also with social distancing, since we have fewer patients coming to the office every hour, possibly, could be 2 patients, and with some telemedicine appointment that are mixed between that. And it's really helped implement this distancing that I think is at this point now and for the near foreseeable future is going to be required. We screen our patients in the office when they come. We provide them with masks. Some of them, Dr. Fieno's mask, and also it's difficult as a physician because we're still practicing the distancing, obviously, except when we have to do the physical exam where we get closer to the patient. But we make sure that we clean the room, between patients. So the whole flow has really changed. Now it's kind of a mix between telemedicine and patients in the office. We are ramping back up. We're currently at 50% of our capacity, and probably within the next week or so, we'll be within 75%. Again, changing a little bit the flow of the visit. And I'm sure it's the same with you, Dr. Fieno and Ahmed in your office.
Identical, Alain, identical. We're seeing that the initial overabundance of caution, which was totally appropriate given the circumstances, is giving way to a different workflow with a whole group of patients being seen telemetrically with audio and video, and then the people who actually need to be seen for a wound check or if they're have a physical exam finding that might be concerning for something acute like a blood clot. They're actually coming into the office. So I don't know what both of your opinions are, but I think this will change medicine forever. And certainly it has changed my practice already.
There's absolutely things like telemedicine. It's one of those things where I'm like, where have you been my whole life? I mean, this is incredible. The patients love some aspects of it. We do. And there's things where you're just going to have to see people in person. But there's some aspects, when you talk about changing the face of medicine, there's some aspects I've seen change, and I'll call them collateral damage, that are very concerning to me. So usually if you have a tight valve, let's say an aortic valve called aortic stenosis, you get some shortness of breath and you get tired and you present to your doctor. They listen to you, they hear a murmur, and they'll get a scan, which will show, there's a actual tight valve there. And then you send them to whoever to fix it. But now we've seen that patient present with a cardiac arrest more than several times in the last few weeks, present after their heart stops and have to get resuscitated, and if they're fortunate, come to hospital. The heart attacks that we're seeing, many of them are presenting later. Instead of after being able to fix them within 1 to 2 hours, which is where you can really, really help someone. We're seeing this up to 48 or 72 hours. And so much damage has been done, you're chasing time backwards. And we're seeing presentation after presentation that I would call a late presentation or a catastrophic presentation, typically because I'm guessing people don't want to seek medical care. And there is campaigns starting in throughout the country, different countries and local communities, to try and tell people, if you need help, you need to go and get help. If your chest is hurting and you're short of breath and you're worried you're having a heart attack, the COVID crisis doesn't change the fact you're having a heart attack. And there's no planet on which staying at home, waiting it out, is going to benefit anyone in that circumstance. That's one of the things I worry about, and who knows how long this whole thing is going to last, and until we know what processes to put in place to make everything streamlined. But that's one of the things that's changed immediately. That damage we're not seeing. I will tell you of one case of someone that had a surgery on their leg and sat at home, and all their appointments with the orthopedist were cancelled because COVID came along, and then suddenly all their appointments with the follow-up and the primary care were cancelled, of course, because COVID came along, and it happened to be in that 3, 4, 5 week period, and the patient just sat at home and stayed still in a cast. And lo and behold, they turn up to hospital with the hugest clot throughout their entire leg, all the way up into their lung, a few weeks later. That's the kind of thing that hasn't been seen yet. There's all these effects and deaths from COVID. But there's this whole other side, which arguably is even bigger, maybe multiple-fold bigger, of what we're seeing not happen for that. So that's something I think important for people to talk about.
I think we need to give our patients the message that it is safe to go visit the doctor at their office. It is safe to go to the hospital. It's probably the safest place, to go because of all the precautions that are being taken. Yes, the dynamics are quite the same, not quite the same. For most cases, we don't allow a visitor, with the patient, but the patient is tested. All the precautions are taken. And we need to really tell our patients that, if they need help, we're there for them. And
definitely, if you're a patient or anyone, stay as fit as you can, be in the best shape you can, keep your medical conditions under the best control you can. Now, more than ever, people need to be paying close attention to things that we know do bad in the long run. But now with this coming along and the unknowns of potential of infection at any time until some vaccine, if it ever comes along, but let's say 1 to 2 years, until that time, people need to be in the best shape they can. And that's something we're telling a lot of people. Don't lose attention to that important detail.
So gentlemen, we've talked about how COVID-19 can affect the heart. It can present as a myocardial infarction or where the artery is completely occluded with a thrombus, and we have to treat with a stent, which is actually still the best treatment for patients with myocardial infarction. I know there was some discussion at some point about going back to the lytics. I think this is a mistake. I think the best treatment for our myocardial infarction patient, whether they're positive COVID or negative COVID, they should come to the hospital and we reopen the artery. Another manifestation is heart failure, acute heart failure, or worsening heart failure. Again, prompting the patient to really seek medical attention, either calling your physician's office or coming to the hospital to be treated. These are, obviously conventional treatment they provide to the patient, as well as, respiratory support for the patients that need it. But I would be remiss if we didn't talk about the treatment of this virus per se and the antiviral, treatment. And I'd love to hear, for example, if any of you are involved in some of the trials. Just briefly, just to mention that we have the antiviral treatment, the chloroquine, as well as hydroxychloroquine, and there's been a lot of discussion about that in the public, particularly when it's combined with Zithromax. Again, none of these medications are recommended per se unless you participate in the trial. Another treatment, antiviral medication, is remdesivir, which is given intravenously on a daily basis. Again, I'd like to know, there's not enough data right now to recommend this treatment, but current studies are ongoing. And I'd like to know, Dr. Ahmed, at the university, I'm sure you have several trials that are ongoing for treatment using antiviral medication for these patients.
Yeah, I think really important what you just said is nothing is known. Treatments that are thought can be beneficial may be very harmful. You talk about the heart and chloroquine, hydroxychloroquine, but we also have to, anyone on that needs to also realize the potential effects that can have on your heart rhythm and the heart tracing. So absolutely, trials are the way to go and find out what's happening. The trials that are ongoing, and if possible, patients are getting into them that present. The antiretroviral that you said, the antiviral remdesivir, that's now just been, I believe, approved, but that's one of the trials that was ongoing. There's trials of nitric oxide, a vasodilator, so something that dilates the arteries of the heart, and that is ongoing. There's trials with the plasma therapy of convalescent patients that have had COVID, and that the plasma is isolated with the potential immune benefits of that given to very sick patients to see if that can help them. Trials, mechanical support as well. So many different possibilities and trials going on and will continue to go on.
So that's very good. Obviously we have the antiviral, but we have also all this immune-based therapy where we try to modify the host and really help, fighting this infection. Convalescent plasma, I think it's got some interesting, prospect. There's not enough data. There's also interleukin 6, which, is, again, being studied, as well as an interferon, where there doesn't appear to be that much difference. An interesting study going on in Montreal at the Montreal Heart Institute is the study of the anti-inflammatory colchicine. And this is obviously for patients that have mild respiratory distress. These are not hospital patients, and to see whether colchicine could hasten recovery. How about you, Dr. Fieno, and any trials going on in the Baptist Medical Center?
Not down at Shelby Baptist. I think the attention right now has been on the social network of doctors that have come together on Twitter, and basically everyone's experience is being reported in real time. And the trend is everybody gets treated with hydroxychloroquine twice a day and azithromycin daily. And then a lot of these folks are watched carefully for compassionate use of the antiviral that you mentioned. The challenge, of course, comes with all of this that we lack the evidence to know what the expected benefit will be, except in limited studies, the New England Journal article on remdesivir that you both alluded to. The other question that we're all trying to wrestle with is prophylaxis for the healthcare workers. So the Italian data, my countrymen, showed that it seems like the healthcare workers are the ones who basically spread the virus all over the place. And the consequence of that is what we've seen, particularly in that aging population that is there in Italy. So the question is, do we as healthcare workers take the bull by the horns, as it were, and take Plaquenil daily, weekly? And once again, we just don't know the answer. We know that in other countries, that's what folks are doing. Tonic water has been described with quinine. The basic fundamental truth of this is that we do feel like we know that managing our lifestyles, comorbidities, staying in shape, as you both have mentioned, keeping a good weight, exercising daily, drinking plenty of fluids, getting good rest, taking care of any chronic medical conditions, lupus, diabetes, hypertension, heart disease, what have you. And then probably considering following up this data very carefully that's coming out of New York, as well as the announcements by the various Centers for Disease Control, FDA, so on and so forth. I think that in the weeks to come, we'll have some of those answers, and we can proceed with the guidelines of evidence-based medicine that Mustafa alluded to a minute ago.
This is very interesting. Obviously, some of that data is starting, to come out, but they're very small studies. For example, in hydroxychloroquine or Plaquenil, which is used anti-inflammatory also for lupus and rheumatoid patient, there was one study that was randomized, but only 30 patients with mild disease. There was no difference. Another study, there was like 62 patients, again, with mild disease, no difference. This was at 400 milligram daily for 5 days. So people have said, well, maybe that's not enough hydroxychloroquine. So in China, they had 150 patients where they gave 1,200 milligram, for 3 days, followed by 800 milligram, very high dose, in patients that had mild to moderate disease. There was apparently more adverse event, mostly GI, and there was maybe some decrease in C-reactive protein and lymphopenia, but we don't have a whole lot of data. Interestingly, in New York, 84 patients in mostly observational study of hydroxychloroquine and azithromycin, they noted 30% increase in the QT interval, which is this parameter on the electrocardiogram that we look at. Usually an enlargement of the QT interval, particularly when it's greater than 450 or even 500 millisecond, can lead to this torsade de pointe, which is this very dangerous polymorphic ventricular tachycardia and can lead to death. They did not report any mortality. And then again, another study, compassionate use of remdesivir on a 53-patient, single arm, no placebo. They noticed that they had, these were pretty sick patients. 30 of the patients were intubated, 4 on ECMO. And they had, at follow-up, a median of 18 days, 6 patients died, or 18%. And all they had to compare, of course, is the natural course of the disease. And the natural course of the disease, as previously reported, for example, in Italy, 26% died. There's some reports in China where there was a mortality for patients on a respirator up to 78% mortality. So, obviously they're small studies. They're not randomized, most of them, small number of patients. I think it will probably take maybe another few months before we get some answers on multi-center, randomized trial. We hope to have more than just decrease hospital stay or decrease ICU stay, maybe some improvement in survival. But really the real treatment is going to be the vaccine. And until we have the vaccine, I think we're just going to try to kind of work on symptoms and maybe improve survival the best we can. Whether we accomplish that, I don't know. This really kind of brings me to the flu season coming around the corner, where we do have a vaccine. And I hope that the COVID-19 has taught us to really to push for the flu vaccine and protect our patients. Because for the patients that are at risk, which are most of our patients, with hypertension, diabetes, heart failure, the penetration of the flu vaccine is only 50 to 60%. So not enough patients are getting the flu shot. And if you have countries, for example, like Spain and particularly Italy, they feel like they're really against this vaccine. Maybe they will change, and this is going to be an eye opener, so that we can really protect our patient with something that can cause as much damage, the influenza virus, but at least we have something to fight it. So hopefully, all the practices will really be pushing for the flu shot for our patients, and patients will be receptive to it. Any lasting opinions? If not, I'd like to thank you, Dr. Fieno, as well as Dr. Ahmed. Appreciate your help, collaboration. I had a little bit of problem with my internet, but finally we were able to kind of complete this podcast, and we may have to come back a month or two from now just for the updates of the clinical trials that we'll have by then.
Pleasure, Alain. Thank you.
Thank you very much.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.